Lifesavers, and welcome back to my channel. My name is Nurse Kelly Tyrrell, and in today's video we are going to continue our pediatric nursing mini-series by covering some more common pediatric cardiovascular disorders and how you as the nurse should be caring for these patients. This is part 2 to the video that I posted last week, so if you haven't caught that one, make sure you check it out after you finish watching this video. But before we jump into it, make sure you subscribe to my channel, like, comment, and share this video with a friend. And make sure you click that bell icon to turn on notifications so you don't miss out on my upcoming content. If you confuse the different pediatric cardiovascular disorders, signs, symptoms, and treatments, then I suggest you keep watching. If you caught part 1 of this lecture last week, then you'll know that we talked about heart defects that increase pulmonary blood flow, causing heavy wear and tear on the veins and arteries. So now let's talk about some defects that cause a restriction of blood flow. So the first defect that causes a restriction in ventricular blood flow is known as coarctation of the aorta. The term coarctation means a tightening or a narrowing. So just like the name suggests, this is a narrowing of the main artery that supplies blood to the entire body, which is that descending aorta. So if you have a kink in a hose, for example, you're going to have significantly increased pressure behind the kink and significantly decreased pressure below the kink, which is why if you press the nozzle of a hose that has a kink, barely any water will come out. Well, this works the exact same way in the body. So you have this narrowing in the descending aorta. So remember from my last lecture, I said that oxygenated blood is pushed out to the body from the left ventricle through the aorta. So if there's a narrowing in the aorta, then you're going to have a significant pressure backing up into that left ventricle and very low pressure throughout the rest of the body. So what you're going to see is a huge difference in blood pressure and pulses between the upper and the lower extremities. You'll have much higher blood pressure and really bounding pulses in the upper extremities, and you may also see nosebleeds because the pressure is building proximal to the defect, meaning above the defect. And on the flip side, you'll see muscle weakness, cool skin, and a thready or a weakened pulse in the leg, since that is distal or below the defect. Your descending aorta sits at the top of your abdomen, so everything above that is going to receive a lot of pressure, and blood flow will be restricted anywhere below the abdomen. Now, depending on the degree of the narrowing, some pediatric patients may be completely asymptomatic at first, and they won't show symptoms until later in their childhood. If they start showing symptoms like what we just talked about, then a diagnosis can be made by conducting a few different tests. A chest x-ray will show cardiac enlargement because the heart is a muscle. So if it's pumping extra hard to force the blood through the aorta, then the heart is going to get bigger and bigger. The x-ray will also show notching of the ribs, which is a very classic sign of coarctation of the aorta. This looks like little arches or rainbows at the base of the ribs, and this happens from increased pressure in those intercostal arteries. You'll also anticipate the doctor ordering an echocardiogram, which will assess blood flow throughout the heart. And as far as symptoms, if a coarctation isn't caught early and it goes untreated, then these patients will develop left-sided heart failure, unlike the defects that we talked about last week, which will cause right-sided heart failure. They can also develop something called ineffective endocarditis. So ineffective endocarditis, also called bacterial endocarditis, is an infection caused by bacteria that enters into the bloodstream, and then it settles into the lining of the heart, a heart valve, or a heart blood vessel. As far as treatments, infants are going to be medically treated until they are strong enough to handle surgery. So you're going to treat these patients like you would treat an adult who has left-sided heart failure, including administering medications like blood thinners, angiotensin converting enzyme or ACE inhibitors, angiotensin II receptor blockers or ARBs, beta blockers, calcium channel blockers, and also nitrates. So once these patients are stable enough to handle surgery, they're going to receive a percutaneous balloon angioplasty or a stent to keep the descending aorta fully open. Now, depending on the grade of the narrowing, the surgeon may actually have to cut out the narrowing and then join the two ends together through a procedure called an anastomosis. And as with any surgery, you want to make sure that you are monitoring for post-op complications, which for this surgery can include abdominal bleeding or obstruction. So you want to be on the lookout for any kind of abdominal pain, nausea, vomiting, and a hard, rigid abdomen. You'll also anticipate giving antihypertensive medications, steroids, and an NG tube to make sure that the abdomen is fully decompressed so it doesn't put any additional pressure on the descending aorta, which can cause a leak or rupture of the repair. All right, so next let's talk about a condition that I am way too familiar with that causes decreased pulmonary blood flow, which is tetralogy of Fallot. So this condition is actually what my older sister was born with, and it's the most complex condition because it actually involves 4 different defects. Hence the word tetra, which means 4. So the 4 different defects of tetralogy include stenosis or narrowing of the pulmonary artery, which will decrease blood flow to the lungs. Also, you have hypertrophy or enlargement of the right ventricle because the heart is working extra hard to pump the blood through that narrowed pulmonary artery. Next, you have dextroposition of the aorta. And if you didn't know, the prefix dextro means right. So it means that the aorta is displaced to the right, which allows blood from both the right and the left ventricles to enter into the aorta, when typically only oxygenated blood from the left ventricle should be entering into the aorta. And the last defect is a ventricular septal defect, which we covered in detail in my last lecture. So as you can imagine, these kiddos are going to be really, really sick, and they're going to need life-saving interventions pretty quickly after birth. One of the first and classic signs and symptoms that you're going to see initially is cyanosis and severe dyspnea that is relieved when you place the baby in a squat position. Squatting is going to increase that peripheral vascular resistance, and you will naturally in turn decrease some of the blood from spilling over from the left ventricle to the right ventricle, which happens with the ventricular septal defect. Other signs and symptoms you'll see are feeding problems because the heart is pumping really hard at rest. So these babies are going to be really exhausted and they're not going to want to eat. You'll also see frequent respiratory infections and polycythemia, which is basically an overproduction of red blood cells. And the reason why this happens is because these babies are going to have chronically low oxygen levels. So the body is going to try and compensate for that by making more red blood cells, since red blood cells contain hemoglobin, which helps to carry and deliver oxygen throughout the body on a cellular level. You'll also see signs of right-sided heart failure, such as swelling, wheezing, or a phlegmy cough. Also central cyanosis and jugular vein distension. Another classic symptom that you'll see specific to tetralogy is something called paroxysmal hypercyanotic episodes, or also known as TET spells. So when a baby has a TET spell, they will have spontaneous cyanosis, respiratory distress, and syncope, which can last anywhere from a few minutes to a few hours, and it can be really, really scary for parents and caregivers. So the best way to help lessen the symptoms and duration of TET spells is to place the patient in a squat or a knee to chest position. Once the TET spell is over, the patient will have a really short period of sleepiness and lethargy, but they usually actually recover fairly quickly. As for diagnostic tests, this defect is going to be diagnosed through a chest x-ray, which will show a boot-shaped heart from that right ventricular enlargement that we talked about. So these patients will also have an electrocardiogram, a 3D echocardiogram, and a cardiac cath to help confirm the diagnosis. Some complications of tetralogy that you'll want to be familiar with is thick blood from the polycythemia we talked about earlier, from that overproduction of those red blood cells. Also dehydration and anemia from the lack of feeding. And these patients are also at a higher risk for developing endocarditis. So you want to make sure that they are on prophylactic antibiotics and that they have really good dental care. As for treatment, you're going to want to treat symptoms of the right-sided heart failure while the patient is waiting to become stable for an open heart surgery with cardiopulmonary bypass to manually fix all of those defects. Medications that you will give for right-sided heart failure can include oxygen therapy, blood thinners, diuretics, vasodilators, beta blockers, digoxin, and pulmonary vasodilators. Okay, so now let's talk about the last common congenital defect, which I touched on slightly in my last lecture when I was talking about PDAs. And this defect is called hypoplastic heart syndrome. So this defect happens when you have a severely underdeveloped left side of the heart, specifically that left ventricle, and hypoplasia of the ascending aorta. So hypo means low and plasia means development or growth. So an underdeveloped ascending aorta. So this patient's survival rate is going to be really dependent on keeping that PDA open with that prostaglandin E medication while they wait for a heart transplant. The surgeon can do a temporary shunting procedure to hold these kids over until a new heart becomes available, but they will not survive long-term without a transplant. As for symptoms, these kids are going to have the common cardiac compromise symptoms, including that cyanosis, dyspnea, CHF, weak pulses, cold hands and feet, lethargy, and a murmur. And this condition is typically diagnosed in utero or shortly after birth through an echocardiogram. A few important nursing considerations to keep in mind, especially for these patients that will need a heart transplant, is you want to make sure that all vaccines are held before and after the transplant while the patient is on immunosuppression therapy. So immunosuppressants suppress the immune system to prevent rejection, but it will also suppress the ability for the child to properly develop antibodies in response to the vaccines. Also, for all children diagnosed with heart defects, you want to encourage, again, good dental care and give antibiotics before any dental procedure because these kids are going to be really prone to developing endocarditis, most of the time from bacteria that is actually starting and originating in the mouth. And lastly, you want to continue to encourage good nutrition and prevent dehydration to avoid complications of anemia and blood clots from the overproduction of those red blood cells like we talked about a little bit earlier. So I hope this lecture was really helpful for you to be able to identify key differences between these different congenital heart defects. And in tomorrow's lecture, we're going to tie it all together with an NCLEX style question review. And that concludes the end of this lesson. I hope that you found this information extremely valuable and it made you just a little more confident as you prepare to take your NCLEX or your next nursing school exam. I just want to thank you all again so much, Lifesavers, for tuning in today. My name is Nurse Kelly Tyrrell, and I help nurses feel more confident, increase their test scores, and retain what they don't remember in nursing school. Speaking of, are you a nursing student or soon to be or ready to take your NCLEX? If so, have you joined my online student community yet? If not, then what are you waiting for? The UNursity community is a complete nursing resource hub all at your fingertips. Inside, you can expect to receive coaching, community, and content. You'll get daily coaching with your mobile mentor, me, Nurse Kelly Tyrrell. You'll also receive access to weekly educational videos that you can watch months before they even publish to YouTube. You'll also get exclusive printable digital downloads like worksheets, quizzes, flashcards, infographics, cheat sheets, skills checklists, and more. And if this video helped you in any way, be sure to give it a thumbs up. Also, don't forget to smash that subscribe button and click that notification bell so you don't miss out on my upcoming content. Also, if you can do me a favor and drop me a comment below, let me know where you're at with your nursing journey. I'd love to just say hi and connect with you. Also, make sure you click that share icon to spread the word and encourage a fellow aspiring nurse. And last but not least, when you are ready to take your NCLEX, be sure to check out my NCLEX and Chill review, where I review detailed test-taking strategies and cover every major topic that you can expect to find on the NCLEX. If you want to have that unfair advantage and pass your NCLEX on your very next attempt, be sure to click the link in the description box below. Not ready to end the study sesh yet? Well, you are in luck, because if you stick around, you can watch more of my videos coming at you in 3, 2, 1. Bye, Lifesavers.